I've spent enough years around operating rooms, late-night emergencies, and conversations with frightened families to tell you something that, frankly, more people should have heard a long time ago. After 70, more testing does not always mean better care. I know that can feel uncomfortable to hear. For many people, it almost sounds wrong at first. We were raised to believe that screening is the responsible thing to do, that catching disease early is always the smart move, and that saying yes to every routine test is simply what careful, sensible adults are supposed to do. And when you're 50, in many situations, that thinking holds up. If you are younger, active, and otherwise healthy, finding a problem early may give you 20, 30, sometimes even 40 more years to benefit from treatment. But here is what almost nobody sits down and explains once you reach your 70s, your 80s, and beyond. The rules change. Your body is not the same body it was at 50. It may still be strong in many ways, but it is different. Recovery takes longer. Reserves are smaller. A procedure that once would have been brushed off as minor can now hit the body like a storm. One day in the hospital can throw off sleep, appetite, strength, balance, even confidence. And because of that, the math of screening changes too. After 70, the danger is not always the illness doctors are trying to find. Sometimes the real danger is everything that starts happening after the test. That is the part I really want you to see clearly. A routine screening finds something a little abnormal. Then that leads to another scan, then a biopsy, then an appointment with a specialist, then a procedure, then anesthesia, then maybe bleeding, maybe an infection, maybe confusion after the hospital stay, maybe weakness that lingers for weeks, maybe a fall in the bathroom at home because the body never quite got back to where it was before. And suddenly, something that began as a simple check just to be safe has taken away independence much faster than the original finding ever might have. I have seen that cascade more times than most families realize. It often begins with a sentence that sounds harmless, even comforting. Let's just check to be safe. But sometimes that one sentence opens a door that never needed to be opened. And once that door swings open, it can be very hard to close again. Now let me be absolutely clear because this matters. This is not an argument against medicine. I am not telling anyone to ignore warning signs. I am not telling you to avoid doctors, avoid hospitals, or turn your back on treatment. I believe deeply in good medicine. I've seen what thoughtful, well-timed care can do. But good medicine is not about doing more simply because more can be done. Good medicine is about pausing long enough to ask a harder, wiser question. Will this test truly help this person? At this age, in this body, in this season of life? Because after 70, the goal is no longer to chase every tiny abnormality in the body, like a detective chasing clues in every corner. The goal is different now. The goal is to protect quality of life, to protect strength, to protect mental clarity, to protect the simple, precious abilities that shape everyday life. Getting out of bed without dizziness, walking across the room without fear, thinking clearly enough to hold a conversation, going to the kitchen, stepping outside, living on your own terms for as long as possible. And in this episode, I'm going to walk you through 5 routine health tests that may sound preventive and reassuring on paper, but in real life, after 70, can sometimes cause far more harm than good. And the first one is a test millions of older adults are still being told to get, often without ever hearing the full story. Let's begin with one of the most common examples of all, the routine colonoscopy after age 75. This is where a lot of thoughtful, responsible people get tripped up, and honestly, I understand why. For years, colonoscopy has been presented as one of the smartest things you can do for prevention. It has been framed as responsible, proactive, even life-saving. And to be fair, for some people at the right age and with the right medical history, that can be true. But once you get past 75, if you are at average risk and you feel well, the decision is no longer nearly as straightforward as people have been led to believe. That is the part most older adults are never really walked through. Here's what often gets left out of the conversation. Colon cancer usually does not arrive overnight like a bolt of lightning. In many cases, it develops slowly, quietly, over many years. A small polyp can sit there for a long time, sometimes 10 years, sometimes 15, before it turns into the kind of cancer that truly threatens life. So if a doctor finds a slow-growing polyp in a 76-year-old who feels fine and has no symptoms, the question should not only be, can we take it out? The more important question, the more honest question, is this: would this ever have actually caused meaningful harm during the years this person has ahead? That is a very different kind of thinking. And after 75, that difference matters more than most people realize. Because very often the real danger is not the polyp itself. The real danger is everything that comes with going after it. A lot of people think of colonoscopy as simply the camera test. They picture the day of the procedure, the quick explanation, the scope, the sedation, and then going home. But I've seen again and again that for many older adults, the hardest part starts before the camera is ever inserted. It starts with the bowel prep. And that is not a small thing in an aging body. That cleansing process can drain the system fast, almost like pulling the plug out of a sink and watching everything rush out at once. The body loses fluid. Electrolytes start shifting. Blood pressure can fall. Sodium and potassium can move into dangerous ranges, and in a younger person, the body may compensate more easily. But in an older adult, especially someone who already gets tired easily, takes blood pressure medicine or has a heart condition, that kind of stress can hit hard. That is how weakness starts. That is how dizziness begins. That is how dehydration sneaks up. How people faint getting up from the toilet, how the heart rhythm becomes unstable, how a routine prep day turns into something the family never expected. I still remember one older patient whose loved ones thought he was simply going in for what they kept calling a standard check. Nothing dramatic, nothing urgent. Just something they assumed was smart to do. But by the next day, he was shaky, confused, and badly dehydrated from the prep alone. The colonoscopy itself almost stopped mattering. What had started as prevention quickly turned into an emergency room visit. Bags of IV fluid, close monitoring, and several miserable days trying to get him back to baseline. He went in thinking he was doing something healthy. He came out weaker than before. And then there is the risk of the procedure itself. When people hear the word perforation, it often sounds abstract, almost distant, especially when it is mentioned quickly in a clinic room. But a perforation is not abstract. It is a tear in the wall of the colon. And when that happens in an 80-year-old body, it is not just an unlucky complication on a consent form. It is a full-blown crisis. Waste leaks into places it should never go. Infection can spread. Emergency surgery can follow. Sometimes a colostomy bag becomes part of daily life after that. Sometimes the recovery is so hard that the person never quite regains the strength, mobility, or independence they had before. That is why I want to say this carefully, because this distinction is everything. If you have blood in the stool, unexplained weight loss, anemia, or a genuine change in bowel habits, that is a different situation entirely. That is not casual screening. That is not just checking. Symptoms change the whole picture. Symptoms deserve attention. But routine screening in a person over 75 who feels well and has no warning signs is a very different medical conversation, and it should be treated like one. And once you truly understand that, the next screening trap becomes even harder to ignore, because it involves cancers we find, name, and treat, even when they may never have harmed that person at all. Now let's talk about two of the most emotionally charged tests in modern medicine: mammograms and PSA blood tests. Because the moment the word cancer enters the room, the air changes. I've watched it happen more times than I can count. A person who was calm 5 seconds earlier suddenly goes quiet. Their spouse leans forward. Their mind starts racing ahead to the worst possible outcome. And once that fear takes over, many older adults stop asking the question that matters most. Is this cancer truly dangerous to me at my age, in my body, in the years I realistically have ahead? That question matters more than most people realize, because of something medicine calls overdiagnosis. And I want to explain that in the plainest, most human way possible. Overdiagnosis means a scan or a blood test finds a cancer that is technically real under the microscope. Yes, but it is growing so slowly that it would never have caused symptoms, suffering, disability, or death during the rest of that person's life. In other words, it is something a person may die with, not die from. But once medicine puts a label on something, it rarely knows how to leave it alone. Take breast cancer screening in women in their late 70s and 80s. Many of these tumors grow at a very slow pace. Some sit quietly for years. Some never become the event that actually changes the course of a woman's life. But once a mammogram picks up a suspicious spot, the machine begins to move, and it moves fast. First comes the callback that ruins a week of sleep. Then the repeat imaging, then the biopsy, then the wait for the pathology report, then the consultation, then surgery, sometimes radiation, sometimes hormone treatment. And while a younger body may absorb that whole sequence with less damage, an older body often pays a much steeper price. That is the part people are not warned about enough. A frail older woman does not simply go through treatment and carry on as though nothing happened. She loses energy, she loses appetite, she loses muscle. Her shoulder may stiffen after surgery. Her sleep may become lighter and more broken. Her walking may become slower. Her balance may become less certain. The confidence she once had doing ordinary things, getting dressed, cooking breakfast, carrying laundry, stepping outside to get the mail, can quietly begin to erode. A test that was supposed to protect her future can end up taking away the very daily life we were trying to preserve. I remember one older patient very clearly. She was still living on her own. She still cooked her own meals. She still walked to the mailbox every afternoon. She still had her routines, her independence, her little pieces of normal life that mattered far more than most people appreciate until they are threatened. Then a routine mammogram found a tiny abnormality. That led to a biopsy. The biopsy led to surgery. The surgery led to a recovery that stretched on far longer than anyone expected, and the truth was heartbreaking. The cancer itself never looked like the biggest threat to her life. The treatment cascade became the bigger threat. Now let's turn to prostate screening. PSA levels often rise as men get older. That by itself does not mean a dangerous cancer is growing. A number going up is not the same thing as a deadly disease. Age can raise it. Benign prostate enlargement can raise it. Inflammation can raise it. Changes that are annoying but not life-threatening can raise it. But once that PSA number comes back high, many older men are pulled into a chain of events they never saw coming. More blood work, more anxiety, biopsy needles, risk of infection. Then long, serious conversations about treatment that sound sensible on paper but can leave a man living with consequences for the rest of his life. And those consequences are not minor. Loss of bladder control, sexual dysfunction, weakness after procedures, complications from hospitalization, embarrassment, frustration, a quiet loss of dignity, a shrinking of normal life. The kind of changes people do not always talk about openly, but feel every single day when they get dressed, leave the house, or try to feel like themselves again. That is why I say this calmly, but very plainly. Many older men will die with prostate cancer, not from prostate cancer. And if a test finds a slow-moving tumor that never would have harmed them, the real injury may come not from the cancer itself, but from everything done in response to it. So what should you do with that information? Not panic, not shut down, not ignore genuine warning signs. A lump, bleeding, persistent pain, unexplained weight loss, or a true clinical concern should always be taken seriously. That is not what I am saying. What I am saying is this. Aggressive screening in older adults who feel well should never be automatic. It should never be something that happens just because that's what we always do. It should be a careful, thoughtful decision based on life expectancy, overall strength, day-to-day function, and what the real consequences would be if something is found. Because the next trap may be even more deceptive. A heart test ordered just to be safe that can turn a healthy older adult into a heart patient almost overnight. You feel fine. No chest pain. No heaviness. No tightness in the chest. No shortness of breath when you go up the stairs, walk to the mailbox, or move around the house. Nothing is happening in your daily life that makes you think, something is wrong with my heart. And then, in the middle of a routine visit, someone says, let's do a stress test just to be safe. And I understand why that sounds reassuring. It sounds careful. It sounds preventive. It sounds like the kind of recommendation a responsible doctor would make and a responsible patient would accept without hesitation. But in an older adult who has no symptoms, That routine cardiac stress test can become one of the quickest ways to take someone who feels perfectly normal and make them feel like a heart patient overnight. Here's the reason. A stress test is not magic. It is not a crystal ball. It does not always separate truth from worry in a clean, perfect way. In people who do not have symptoms, especially older adults, it can produce what doctors call a false positive. That simply means the test suggests there may be a problem with blood flow to the heart, even when there is no dangerous blockage actually causing harm. In plain terms, the alarm sounds, but there is no real fire. And once that alarm sounds, everything can start moving very fast. First, there is the abnormal test result. Then comes the referral to a cardiologist. Then comes more discussion, more concern, more language that makes everything feel urgent. And after that often comes the angiogram, where tubes are threaded into the blood vessels so doctors can look directly at the coronary arteries. That step is often described so casually that people imagine it as something simple and almost routine, but I've been around these procedures enough to tell you plainly, it is not nothing. It is still an invasive test. Bleeding can happen. Blood vessels can be injured. The contrast dye can strain the kidneys, and in some older adults, yes, even a stroke can happen. So think about what that really means. A person can go from feeling completely well to being exposed to serious procedural risk, all because of a test that may never have been necessary in the first place. And here is the part that surprises many people the first time they hear it. Even if a blockage is found, that does not automatically mean a stent is going to help. That is where a lot of older adults and their families get caught off guard. They naturally assume that if a narrowed artery shows up on a scan, opening it must be the life-saving answer. It sounds obvious. It sounds logical. But for stable patients, people who are not in the middle of a heart attack and are not having active symptoms, that is often not how the story actually works. A partial blockage can look dramatic on an image, and the image can be frightening, but putting in a stent does not automatically lower the chance of a future heart attack or extend life compared with careful medication, blood pressure treatment, cholesterol control, and close follow-up. That is why the real danger is not just the false alarm itself. The real danger is the road the false alarm puts you on. More testing, more procedures, more medical labels, more fear, more appointments. More risk placed on a body that may have been functioning just fine before anyone started looking for a problem that was not showing itself in real life. I have seen older adults walk into a clinic feeling normal, steady, and independent, and walk out carrying a whole new identity they did not have that morning. Heart patient. And sometimes that shift did not begin with chest pain or collapse or an emergency. Sometimes it began because someone went searching for trouble where no symptoms existed. So here is the practical rule I want you to hold on to. Test symptoms, not anxiety. If you have chest pain, breathlessness, fainting, pressure with exertion, or any real warning sign, that changes the picture completely. That is different. That deserves attention. But if you feel well, the phrase, just to be safe, is not always as safe as it sounds. And the next so-called preventive test may be even more misleading, because it focuses so much on a number on a scan that it can distract people from the thing that truly shatters older bodies every single day, the fall. Now let's talk about bone density scans, because this is one of those areas where the intention sounds right, but the focus can quietly drift in the wrong direction. And I want to say this plainly from the start. The fear behind this is completely understandable. Falls are not minor events in older adults. They can change everything. I have seen what one broken hip can do to the rest of a person's life. I have seen one fall take someone who was still living independently, still making breakfast, still watering the plants, still walking from room to room without help, and suddenly turn that person into someone who needs a walker, a rehabilitation stay, or constant help just to get through the day. So when a doctor says, "Let's check your bones," it sounds reasonable. It sounds sensible. It sounds like exactly the kind of thing we should be doing. But this is the part most people are never really taught to think through. The scan gives you a number. That is what it does. It measures bone density, but it does not measure whether you are likely to catch your foot on the edge of a rug. It does not measure whether your legs are getting weaker. It does not measure poor balance, dizziness when you stand up too fast, blurry vision at night, slippery bathroom floors, steep stairs, or the sleeping pill that leaves you groggy and unsteady at 2 in the morning when you are trying to make it to the bathroom in the dark. And yet, once that bone density number comes back low, the system often starts moving in one very predictable direction: medication. That is the gap in the logic. The scan points to thinner bones, and almost immediately the answer becomes a prescription, often a bisphosphonate. Now, to be fair, these drugs can help some people in the right situation. I am not denying that. But the story becomes more complicated when they are used for years and years, especially in older adults whose bodies are already dealing with other vulnerabilities. Bone is not a dead material like plaster on a wall. Bone is living tissue. It is constantly breaking down and rebuilding itself. It is meant to renew. It is meant to adapt. And when that natural process is altered for too long, the bones can begin to behave in ways that are not quite normal, sometimes denser on paper, but not necessarily healthier in the way they tarmal everyday stress. And that is where the paradox begins. A medication that is supposed to lower fracture risk can, over time, increase the risk of a very unusual kind of thigh bone fracture, the kind that can happen with surprisingly little trauma, sometimes after nothing more dramatic than stepping wrong or turning the wrong way. Then there is the jaw complication, which many people dismiss because it sounds rare and far away, until it happens to someone real. Poor healing after dental work, exposed bone, pain, difficulty eating, a long, draining dental ordeal that can stretch on and on for an older adult who thought they were simply doing the responsible thing to protect their bones. So then the real question becomes, what actually protects older adults? Not just a number on a scan, not just another medication added to the pill box. The real protection is fall prevention. That is where the real difference is often made. Better balance, stronger legs, a grab bar in the bathroom, a handrail where there should have been one years ago, brighter lighting in the hallway, removing loose rugs that slide under your feet, wearing shoes with grip instead of slippery socks on smooth floors, reviewing medications that cause dizziness, drowsiness, or drops in blood pressure, making the home safer in practical, everyday ways before the body pays the price. That is the shift I want you to make in your mind. Stop focusing only on the image and start protecting the life happening around that image. Stop treating the scan result like the whole story and start looking at the hallway, the staircase, the bathroom floor, the medication list, the balance, the vision, the daily routine. Because the next test may sound even more reassuring, a simple ultrasound of the neck, but in the wrong person, it can lead straight toward the very stroke it claims to prevent. Now let's move to a test that can fill a person with fear in a matter of seconds, often before they have even had time to understand what they were told. They found 70% blockage in your neck. I have seen the reaction to those words more times than I can count. You can almost watch the blood drain from a person's face. In an instant, their mind jumps straight to the worst-case picture: a stroke, a wheelchair, slurred speech, a hand that no longer works, a life that suddenly depends on other people for the most basic things. And once that fear grabs hold, very few people stop long enough to ask the one question that matters most. Does this picture on the screen really mean I am in immediate danger? Because here is the truth that is almost never explained in a calm, understandable way. Finding blockage on an ultrasound is not the same thing as having an emergency. It is not the same thing as having an active stroke. And it is definitely not automatic proof that surgery is going to help you more than it could hurt you. But once that ultrasound report says there is narrowing in the carotid artery, the whole machine starts moving again. A referral, a specialist visit, more serious-sounding language, a conversation about opening it up or cleaning it out. And this is exactly where things can become much more dangerous than people realize. The procedure that is supposed to prevent a stroke can, in some cases, be the thing that causes one. Why does that happen? Because this is not like clearing debris out of a pipe under your sink. This is delicate work on one of the main blood vessels feeding the brain. Plaque can break loose during the procedure. Blood flow can be interrupted. A clot can form. A fragment can travel where it should never go. In other words, the treatment itself can trigger the very disaster everyone was trying so hard to avoid. And this becomes even more important after 70, because age changes the whole equation. Frailty changes it too. An older body, a weaker body, A body already carrying heart disease, kidney issues, diabetes, balance trouble, or general physical decline does not absorb surgical stress the way a younger body might. So a number on a scan can look dramatic, sound urgent, and push someone toward an operation whose risk may actually outweigh the danger of the blockage itself. That is why major medical groups do not recommend routine carotid ultrasound screening for people who have no symptoms of stroke. No mini-stroke, no sudden weakness, no loss of speech, no facial droop, no numbness on one side. When someone feels well and has had none of those warning signs, screening often uncovers findings that create fear and trigger invasive decisions without clearly improving what happens in the long run. So this is the action line I want you to carry with you. Never confuse an image with a destiny. A scan can show something real, yes, but that does not mean it automatically needs to be chased with a procedure. It has to be weighed against actual benefit, actual harm, and the reality of your age, your strength, your health, and the life you are trying to protect. Because now we come to the most important part of this whole conversation. If all of these tests can sound wise on paper but become risky in real life, then how should you make smart, steady, clear-headed decisions after 70? Now let me make what I believe is the most important turn in this entire episode. This is not about turning your back on medical care. This is about learning how to choose the right care. I am not asking you to distrust every doctor, every clinic, or every test that gets mentioned in an exam room. That is not the message. The message is that after 70, wisdom has to matter more than habit, more than momentum, more than simply saying yes because that's what people do. Good medicine is not only about what is available or what is possible. Good medicine is about what actually makes sense for you, your body, your age, your strength, your priorities, and the kind of life you are trying to protect. And there is one distinction here that changes almost everything. Having symptoms is not the same thing as being sent for routine screening. If you have blood in your stool, unexplained weight loss, crushing chest pain, shortness of breath, a lump in the breast, weakness on one side of the body, trouble speaking, fainting, or some sudden major shift in how you feel, that is a different situation entirely. That is not some routine box being checked on a preventive care list. That is your body waving a flag. That is your body saying, pay attention, something is different here. But when you feel fine, when you are still going about your day, making coffee, walking through the house, getting dressed, watching television, sitting down to dinner, and someone wants to order a test simply because it is standard or routine, that is the moment to slow the whole conversation down. And this is where I want to give you 4 questions that can protect you. I mean that sincerely. I believe these 4 questions can save older adults from a tremendous amount of unnecessary fear, unnecessary procedures, and unnecessary harm. First, what exactly is this test looking for, and what happens if you find it? That question brings the conversation back down to earth, out of medical language, out of vague reassurance, out of that hazy feeling of, well, I guess it's probably a good idea. It forces everyone to talk in real-life terms, because finding something is not always the same as helping someone. Sometimes finding something is the first domino in a chain of events you never needed to start. Second, if you do find something, what would the treatment be? And what are the risks of that treatment at my age? This is the question too many people ask too late, after the train has already left the station. They focus on the scan, the blood test, the screening itself, but very often the true cost comes later. It comes with the biopsy, the procedure, the anesthesia, the days in the hospital, the weakness afterward, the complication nobody expected. At 78, at 82, at 87, the treatment road matters just as much as the diagnosis at the end of it, sometimes even more. Third, what happens if I do not do this test right now? That is not an irresponsible question. It is not a foolish question. It is one of the smartest questions an older adult can ask. What is the real risk of waiting? What is the actual chance that this issue would ever grow into something that changes your life? What are the odds that careful, watchful waiting is safer than jumping into testing just because it feels proactive? Many older adults are never told that sometimes not now is not neglect. Sometimes it is the most thoughtful and medically appropriate choice on the table. Fourth, is there a less invasive way to get information that would still be useful? Sometimes there is. Maybe the better answer is to watch for symptoms instead of rushing straight into a procedure. Maybe it is a stool test instead of an invasive exam. Maybe it is checking blood pressure at home, in your real daily life, instead of chasing one dramatic reading in a medical office. Maybe it is reviewing your medications, your walking balance, your dizziness, your fall risk, or the way you are actually functioning from day to day instead of ordering yet another machine-based test. Have you noticed what all four of those questions have in common? They bring medicine back where it belongs. Back to you. Back to your life. Your daily function. Your peace of mind. Your goals. Because after 70, the goal is not to win some invisible prize for getting the most tests, the most scans, or the longest problem list in the chart. The real goal is much more human than that. The goal is to stay sharp enough to think clearly, steady enough to walk safely, strong enough to live independently, well enough to sleep in your own bed, use your own bathroom, move through your own home, and stay out of the hospital whenever that can safely be done. You have every right to ask questions. You have every right to understand the downside before you agree to the upside. And yes, you have every right to say no when a test does not clearly protect your health, your function, or your quality of life. And in the final part, I want to leave you with the one truth I wish more families understood before one routine decision quietly changed everything. So, let me leave you with the truth I wish more people understood before one routine appointment quietly changed the direction of their later years. After 70, more testing does not always mean better care. That does not mean medicine has failed you, and it does not mean doctors are the enemy. What it means is that the goal of medicine has to change as the body changes. When you are younger, the system is often designed to search hard, find problems early, and move quickly. And in many cases, that makes sense. But later in life, the wiser goal is often different. The wiser goal is not to chase every faint shadow on a scan, every slightly abnormal number on a lab report, or every finding that may never have touched your real life. The wiser goal is to protect your strength, your clear thinking, your balance, your mobility, and your independence. The things that determine whether you can still get out of bed safely, make your own breakfast, walk across your living room, enjoy a conversation, and remain in charge of your own day. I have seen too many life-changing complications begin with decisions that sounded small in the moment. A routine screening. A just-to-be-safe procedure. One mildly abnormal result that led to another test, then another opinion, then another appointment, then a treatment plan that slowly took more from the patient than the original problem ever would have. And that is the part families so often do not see coming. They think the danger, if there is any, will come from the disease. But sometimes the real damage comes from the cascade. The biopsy, the anesthesia, the recovery, the weakness, the confusion, the hospital stay, the fall afterward, the loss of confidence, the loss of normal life. That is exactly why wise questions matter so much, because those questions protect more than a chart. They protect your real, everyday life. They protect your ability to wake up and think clearly in the morning. They protect your ability to walk safely to the bathroom at night without feeling faint. They protect your time at the dinner table with family, your energy to go outside, your confidence to live in your own home, your chance to stay out of the hospital, and your ability to remain yourself for as long as possible. That is what we are really trying to save. Not just years on paper, but life inside those years. So now I want to ask you something personally. Which test in this episode surprised you the most? Which one made you stop and think, no one ever explained it to me that way before? And would you bring these 4 questions with you to your next doctor's appointment? Tell me in the comments. I truly mean that. I would genuinely like to know what stood out to you, because your experience may help someone else ask a better question before saying yes too quickly. And please share this with a parent, a spouse, a brother, a sister, a friend, a neighbor, anyone over 70 who may be told to go along with a test before anyone ever takes the time to explain the full risk, the full trade-off, and the full reality of what can happen afterward. Sometimes one conversation had at the right moment can spare a person from a road they never needed to go down. And one more important note before we close. This content is for education only. It is not personal medical advice. Do not ignore symptoms. Do not stop medications. Do not refuse, delay, or change doctor-recommended care without speaking with a licensed clinician who knows your medical history, your medications, your risks, and your specific situation. Ask wisely, decide carefully, and protect the years you have worked so hard to reach.